Hello, everybody. This is Aaron Williams. I'm glad to be here today, and also, very encouraged by the poll results that indicate that about 92% of you all are going to be implementing SBIRT at some point, or at least looking at implementing SBIRT. I think that's very encouraging. And I'm very happy to be on this webinar and kind of, give you an overview of SBIRT, but also looking at a project that myself and Mike Laudieri participated in over the last 6 to 8 months, and try to provide you with some lessons from the field around the implementation of SBIRT. So if we go to the next slide here. Yeah, the next slide. Okay, so just to give everyone an overview of what we're going to do today over the next hour to hour and a half is really just give folks a brief overview of SBIRT, sort of what it is, and kind of orient them to that, given that there are a few people on the call who don't know quite as much about it. And then we're going to talk about areas of consideration and implementation. And this is really based largely on some of the efforts that we undertook in Ohio through a project that myself and Mike Laudieri were working on. We came up with about 4 sort of areas of consideration that we'll talk about today on the call: workforce development, workflow, developing workflow, partnership development, and billing. And then Nancy, my colleague there in Nevada, is going to be talking about some new research and some new information about different types of technology that can be used to help facilitate SBIRT and the SBIRT process. So that will be what we'll be covering today. And as as was said earlier, please feel free to either ask questions through raising your hand in the chat box, or there'll be some time for questions at the end as well. So if we can go to the next slide. So, okay, this is just sort of a brief overview. So what is SBIRT really? What are we talking about when we talk about SBIRT? Screening, brief intervention, and referral to treatment. We're essentially talking about a comprehensive, integrated, public health approach, to the delivery of early intervention treatment services. So if you think of sort of the changing landscape of healthcare in this country, one of the things that became quite clear when looking at the research is that there's a need for screening and brief intervention around substance use issues, intervening with folks much earlier in the process and course of substance use disorders, and looking at other places and ways in which we can do that. SBIRT was essentially designed to address that need. So really, it's a comprehensive public health approach, looking at getting people who have substance use disorders, or people who are at risk for substance use disorders, into treatment and support, as needed. So if you think about where SBIRT can be implemented, it can be implemented in primary care centers, trauma centers, emergency departments. We'll talk a little bit more about the other places it can be implemented. But the point here is that SBIRT is designed, to be pushed out into the community. So this is, moving these services away from traditional behavioral health agencies, and kind of going to the people, if you will, and providing those services in other areas. Next slide. So this is just an example of some of the places that SBIRT, has and is being considered in terms of being implemented. So you're looking at individual providers, so doctors' offices, individual practitioners, other community clinics, facilities, home health care. SBIRT has been done in those settings, residency programs, urgent care facilities, FQHCs, federally qualified health centers, rural health clinics. You also have emergency rooms. I think there's a lot of efforts and information about SBIRT being implemented in emergency rooms and ERs. Also hospitals, residential treatment group homes, if they aren't otherwise doing SBIRT. Also, in terms of the larger community, there SBIRT services can be delivered in schools, particularly for folks in rural areas. It has been delivered using telemedicine, so via telehealth sort of mechanisms. And also there's some interest looking at potentially doing SBIRT-related services in call centers. Next slide. So just a little bit more about the goals of SBIRT. So really, we're talking about trying to encourage healthcare providers and other professionals, to screen for these illnesses. There's a lot of data about, how many people, actually receive services, substance use treatment, as opposed to the overwhelming need for those services. I believe SAMHSA reports that, about 2 million or so people a year receive services for substance use disorders, yet more than 20+ million people, actually still need those services. A part of the SBIRT process to really try to connect with those folks who otherwise wouldn't receive any sort of service or support, and also to address, issues around those risky behavioral health patterns, so risky users or harmful users. Folks who may not necessarily meet criteria for abuse and dependence. I mean, that's changed a little bit with DSM-5, but those who wouldn't necessarily reach those sort of diagnostic criteria, but may be using substances more than they should, given pre-existing health conditions, diabetes, high blood pressure, other things, or just using too much given their sort of personal circumstances. So also you want to improve the linkages between general community health care and specialized substance abuse treatment providers to facilitate access when needed. We'll talk a little bit about this in terms of the relationship between healthcare and community substance use providers, but definitely looking at strengthening that relationship and getting healthcare providers and substance use providers really working together to address the community's problem is also a core component of SBIRT. Next slide. So if you just look at this, this is sort of a cheat sheet around SBIRT and looking at how you can triage sort of individuals who come in and receive screening. So if you think of the screening as just sort of identifying the problem, whether it's an alcohol or drug problem, tobacco, depression, or anxiety, there are a number of different screening tools, evidence-based screening tools that address each one of those particular disorders or conditions. Looking at assessing the level of risk there. So if folks who are at low risk, you really want to raise awareness of the issue and spend some time trying to motivate them to change. People who are at more moderate risk or a little bit higher on these scales, you want to provide some brief treatment, maybe cognitive behavior therapy, solution-focused therapy, other things, or maybe even some medications. And really help them in terms of acknowledging risk and seeking that further help or support with their particular problem. And also those at higher risk or those who already meet criteria for abuse and dependence when they come into any particular center, you want to have some supports and refer those to more formal substance use or mental health services, whichever one may apply. Next slide. So we want to talk a little bit about our experiences, doing a project with the state of Ohio. We worked with the Coalition for Drug-Free Greater Cincinnati. They had a grant from a private, a private foundation there. I think it's called Interact for Health. I believe they just changed their name. So Interact for Health gave a number of different agencies some funds to begin implementing SBIRT. So we were brought in by the Coalition for Greater Drug-Free Cincinnati, and we worked with them as well as about 6 other agencies. Some of them were school-based agencies. Some of them were health centers. Others were community anti-drug coalitions. And all of them had an interest in implementing SBIRT with their particular populations. So we came in and worked with them for about 6 months. We came in with an initial day-long SBIRT training. We really talked and got into much more core issues around screening, brief intervention, referral to treatment. Really sort of discussed a lot of the nuts and bolts of SBIRT. And then we came back about 3 or 4 months later, after they had begun implementing their projects, and went out to each of the different sites and had a one-on-one consultation with each of those groups, and really sort of trying to hone in on any particular issues that they may have had, looking at different ways in which they could address those issues and kind of work through any sort of problems that were occurring as they began to try to implement that. So out of that, I think we came, for us, several points of consideration, for anybody we think trying to implement SBIRT going forward. Next slide. So those core areas of consideration, as we talked about earlier, workforce development, developing the workflow for that process, partnership development, and of course billing. I mean, billing is going to be a key issue in terms of sustainability of any of these efforts. Really getting it up and running, gets people engaged and keeps them moving in terms of making sure they have a mechanism to pay for the services once offered. That's a pretty significant issue. Next slide. So let's look at workforce. Next slide. So if you think about, SBIRT and, looking at some of the workforce issues or workforce concerns, in order to really provide these services, providers will need, typically will need a more diverse skill set. So making sure that providers are well versed in brief counseling techniques, whether that's MI, motivational interviewing, brief cognitive therapy, solution-focused therapy, or others. Making sure they're really well versed in those and pretty skilled in delivering those particular services. One of the things that came up during our visits with a lot of the centers in the Ohio area was this transition for a lot of the providers in terms of working with health centers or working with other environments, and really having to focus on these kinds of quick 15, 30-minute sessions and really be able to, deliver a concise, compact message and work with clients in that short period of time. I think as most providers know, a lot of behavioral health addiction treatment providers are really used to those kinds of 60-minute, 50-minute or 60-minute billable sorts of sessions or group processes. And really to implement SBIRT and do that well, you really have to be thinking about these, shorter interventions and being particularly well versed in those. Also looking at the knowledge of the relationship between substance use and other health conditions. So if you're thinking about implementing this, particularly in a hospital or health care center setting, folks will come in and they'll have, other comorbid conditions. Maybe it's diabetes, maybe it's hypertension, heart disease, other issues. And really having a working knowledge of, how substance use relates to those particular issues. That'll be critical in sort of, getting buy-in and support from, the agency that you're working with and from the clients, that you can really kind of reference the importance of addressing these substance use issues relative to the actual, illness or diagnosis that they came in to see the physician or the primary care personnel for. Care coordination. If you are, working in these diverse settings, you're going to be asked to work with a number of other diverse stakeholders. You're going to be asked to work with primary care staff or, school staff if you're working in a school. Potentially, if you're not providing treatment services in-house, you'll be asked to work with outside outside agencies for referral. So really looking at how you can kind of triage and coordinate that care, having some skill there will also be sort of critical. Knowledge of addiction treatment medications. I think as most folks may know, we're in sort of I won't say new frontier, but we're in a time in healthcare in which there are a few medications that are shown to be effective around addiction treatment. There's a lot of evidence that they are underutilized, and they could be beneficial as a part or as an adjunct to traditional behavioral health treatment. So having a working knowledge of that, particularly in healthcare settings, given that you'll have access to prescribers and clients may come in really asking questions about these kinds of things, having a good working knowledge of these medications, how they can be helpful, how they work on the body if folks come in who actually are using those medications or being maintained on those medications, will be really helpful as you begin to move forward with any sort of SBIRT process. Knowledge of other evidence-based practices. The landscape through the ACA and mental health parity has really changed, so there's a tremendous focus on the use of evidence-based practices. So making sure you're skilled on these particular evidence-based practices around substance use. You have good programs in place wherever you're working to kind of pull those in. Good clinical supervision of those programs will also be critical for you going forward. So next slide. So in addition to that, you're going to, have to address clients that are going to come in with a much more varied substance use history than you may be accustomed to working with in a traditional treatment setting. You really may, I think one of the things also that as we worked with the folks in Ohio that, again, became quite clear, they were very used to working with clients and helping clients who come in with, severe and significant substance use challenges. May have, a lot of, social issues related to substance use, may be, have a relationship with the criminal justice, may have, really serious problems in terms of, life events and sort of, their status, with regard to that. So they're very skilled in working with those folks. But, in some of these settings, you're going to see people who, may be having problems with substance use, but may not be quite, may have a higher level of sort of functioning. How are you going to address those issues and those concerns with, this patient population? How can you really sort of tailor your message to people who really, aren't experiencing the same sort of life challenges as those who, we're accustomed to working with, who come in, with severe sort of addictive disorders. So really having, an ability to kind of transition from one group to the other and really work with, those folks who are coming in who, again, are having challenges relative to maybe certain health conditions or who are looking to cut back or, reduce use, in order to achieve some sort of life goal, as opposed to people who really have some, more significant issues, really having some skill in kind of making that transition and moving forward. Again, also substance users who are coming in with multiple chronic disorders, as we talked about earlier, having, some knowledge of how substance use relates to that. How their health is being impacted by these other chronic health conditions, how that impacts their ability to, work with you, to receive treatment, to, be responsive to any sort of treatment approaches, that's a skill that I think, providers will really need to make sure that they have and are really sort of, working on. Also just in general, the concept of really doing these things or providing these services in, very diverse settings, working with different people, people who may not, have as much familiarity with traditional treatment as you, and really working in environments where you're working in sort of 15-minute intervals. You have to be clear, concise, working as a part of a care team. So having, different folks, whether it is the primary care doc or, the nurse or, other administrators, all involved in the person's care and how you, relate back and forth to them, to those providers, again, will also be critical, in this process. Next slide. So let's talk a little bit about this issue of workflow. In order to really, next slide, thank you. So this is kind of just another sort of a visual representation from SAMHSA, sort of a a cheat sheet of thinking about sort of screening and how you may want to triage, people who come in and screen positive, or some people you screened for SBIRT. I'm screened for substance use. So if you just look at it, again, thinking about this, so if they're low risk, you really just want to reinforce or, give some positive behavior, reinforce positive behaviors, and really you don't need a whole lot of intervention at that point. People at moderate risk, again, you want to have a brief intervention to really talk to them about what may be going on with their substance use and how, either reducing or cutting back might be something that they should, really be looking at. Moderate to high risk, you may want to actually have some really, brief and focused treatments, maybe even a couple of sessions, really talking to them and targeting them, reducing or quitting, the substance use behavior, altogether. And also those with severe risk or already at dependency. Definitely looking at how you can work with them, but, making sure that you have those referral supports and referring them to more formal treatment, as necessary. But the critical thing here is that in order for you to implement, any sort of SBIRT process, you have to have a good, sound workflow of how you're going to, screen a patient, move them, what happens if someone screens positive, who treats them after that, who's the next provider in line that gets to see them, how that workflow moves forward. So that will be critical as you move forward with this process. Next slide. So this is this is part of a document from a consultant that we've used before, Bill McFeature in Southwest Virginia, who kind of developed sort of a workflow around SBIRT. And in this workflow, he actually ties a number of the billing codes to some of the actual activities as a part of the SBIRT workflow. Now, there are a number of workflows out there. I just kind of put this in as a bit of an example, but there are lots of folks out there who have other examples of workflow around SBIRT, a lot of good material that's on the web around that. We have some at the Center for Integrated Health Solutions. There are a number of those things, with the SBIRT ATTC as well. So really there's a lot of information out there, but this is just an example of sort of, if you have a patient come into a primary care or a private practitioner, how you can kind of move a process forward. So, patient comes in, does kind of the normal registration, HIPAA, medical history things. They go in and they have their vitals done, and you can put in, as you see, an SBIRT screen. I think they're using a cage there as a part of that examination. Then you have a positive result. Then you can go down. Next slide. You have a positive result. There are a number of different ways in which that can be triaged. You can have the PCP, look at that, more formal screen, really to decide and provide that preliminary diagnosis. Then you can really, have them take a look at that, look at any sort of associated behavioral health symptoms, and then it can be referred over to, if you have a behavioral health provider as a part of this process, to talk about, the sort of feedback, prevention, counseling, discussion of, lifestyle issues related to the substance use, management issues. As I said, in this one they have some of the, the billing codes attached to this, so you can really take a look at how you can do this, having the workflow set up and, tying that back to billing. We'll talk about billing a little bit later, but there's also a number of different resources through CMS on their website about eligible providers for billing, and also the codes that are typically used. But we'll discuss a little bit of this in just a second. Next slide. So again, sort of the critical thing here is really you have to, once you decide that you're going to do SBIRT, you really need to take some time with your entire team and work on that workflow. Getting that workflow right will be really critical in terms of, maintaining and sustaining the process, but also maintaining and sustaining buy-in from your staff. Your staff will really sort of get turned off to the process pretty quick if they have a workflow that seems either redundant or unclear, or they just aren't really comfortable with it fully. So when you think about workflows, you definitely want to develop the workflow for your individual organization, making sure that's clear, who's doing what within your own sort of organization. But you also want to look at it in terms of the broader system of care that you're doing business with. So if you're working with outside providers who are providing the referral to treatment, or if you're bringing in a behavioral health clinician, to provide some of that brief intervention on site, you really want to make sure that they are included in that workflow. That workflow includes a smooth transition to any of those points, even if it is to outside referral. Making sure that you address issues of, how far away is the referral source? What happens when you send a referral over? Do you get feedback about, what's happened with the client? What's that larger relationship like? So really think about, the workflows and developing that, in the individual organization first, but then adding in those layers around the larger system of care you're doing business with. Next slide. So another one of the elements here that we looked at, the issue of partnerships. Next slide. Partnerships, in developing these processes are really, important, really critical, and I think, Nancy and others, on the call can kind of attest to, the fact that one of the things that comes up a lot when you talk about SBIRT is that a lot of agencies experience some level of hesitance in trying to implement an SBIRT process, primarily because if people screen positive, and they need, additional referrals or attention, they, don't know or don't have the connections in which they can refer folks to. So definitely, looking at, developing those partnerships, and that was something that we saw, in our experience was there was just a lot of, work that needed to be done in terms of developing those community referrals. Agencies that had, been right next to each other for years, but had never actually, referred patients to each other. You had, but both had, lots of substance using folks coming in, no place to really send them, but of course they had a treatment program down the street and really hadn't, broached each other about a relationship. So really looking at this, couple of the points here to highlight is sort of what is the referral, mechanism, the relationship. So what is your system of care? Who's in your community? If you think of substance use as a community problem, and you look at yourself as kind of an agency or a cog in that wheel of the community, who else is in the community that may be either experiencing this problem or can help you in terms of addressing the problem? Looking at what that system of care is. Who's in your network? What services are provided through your network? What, are you, if internally maybe you provide some outpatient treatment so you have kind of that covered, what if, someone comes in and needs residential? Do you have providers that you're connected with, that you have business agreements with, that you have formal relationships with, that can, help you with that process, in terms of referrals or in terms of moving them over transitions of care. If you're an agency that maybe you have those things in place, but you're looking at, someone who comes in and needs to use addiction treatment medications, buprenorphine or Vivitrol, for example. Do you have the providers, the service array, in-house to provide those services, or where you have to, refer out, like where are those other community supports? You may have to conduct outreach and engage community partners to enhance the network. This is an issue with quite a few agencies, as I said earlier. They just haven't done a lot of work in terms of looking at the community, really developing those contacts in the community, that will help expand the service array that they have. That's going to be critically important if you're looking at sustaining SBIRT. Next slide. So again, partnerships are important. Can't emphasize that enough. So if you have partners, so start with the providers you already have a relationship with. If you're thinking about implementing SBIRT, this might be a good time to go and sit down with any of the partners that you have and talk to them about this new initiative and how you might want to go forward. Go slow with that process. So one of the things that we talked to a lot of the folks in Ohio about was this idea of, what if you talk with your partner about, a potential pilot. So maybe let's look at, we will do this SBIRT process or develop this referral process for substance use, for 3 months or 6 months. And then we will, go back and revisit that to see where we are, to really track it, to see how many referrals you guys have gotten, what has happened to those referrals. Do we need to tweak the workflow? Those kinds of things. So again, try out that new service delivery process for a short period of time and revisit. Think of this as a process improvement initiative. And really kind of go slow until you kind of hone the workflow and then ratchet it up from there. Next slide. So, one of the last sort of major elements that we talked about here is billing. Next slide. So this is just a really sort of a screenshot of the different codes that are available through commercial insurance, Medicare, and Medicaid that are related to SBIRT. Giving you an idea of how much some of these codes, how much some of these different activities can be reimbursed for. Definitely, you want to make sure that you are consulting your local providers of these to see, what's reimbursable, how that works in this particular state, if codes are turned on and those things. But this is just to give you a snapshot of some of the things that are available, around that. So next slide. So one of the ways in which, maybe a good idea for you to frame this in terms of billing is, really looking at this sort of ask, assess, advise, assist, arrange model. I believe this model was initially used around tobacco cessation and it's been sort of adopted to more broadly to other substance use issues. Looking at that initial sort of ask and asking about substance use, then assessing kind of the nature and the risk of that substance use, and then tying it here to some of the codes that might actually be applicable. So then if you go to the brief intervention, looking at that, looking at those brief interventions, so advising, the client of, the substance use, so, saying things there like, I think that it looks clear that you have some sort of substance use disorder, talking to them about it, then providing sort of those interventions and assisting them in terms of addressing it, then arranging either follow-ups or referrals, and then, again, having those, codes kind of tied to that process. Next slide. So, again, this is just kind of that same sort of, process is giving you a little more detail about that. They kind of ask, permission to talk about substance use. And this is kind of the initial, preliminary screen here, so there's no, billable code attached to that. Next slide. But here you have sort of the more, the larger scale assessment of your substance use or alcohol use. And again, there are billing codes attached to these particular activities and triaging that. Next slide. Again, the advised, these are some possible billing codes there. Looking at, how you, talk to them about this. You are drinking more than is medically safe. I recommend that you cut down or quit. Let's talk about this further. Next slide. Again, so assist, agreeing to a plan to really talk about specific steps and how, you're going to address the substance use. looking at assessing kind of the readiness with the change, really kind of looking at how you can increase motivation for change, talking about this whole process and moving that forward. Next slide. So then the range. So reinforcing adherence, renegotiate goals as necessary. Looking at return visits, continued support, referrals of treatment. All of those things are there. Next slide. So just to kind of summarize this a little bit, the codes that you use are going to depend on the setting. So if you're billing private insurance, you definitely want to look at the CPT codes. If you bill Medicare, looking at the G codes. If you're using them in a clinic and you're using a mix, you want to use the CPT codes for your private insurance, G codes for Medicare, and use the H codes for Medicaid. These are just rules of thumb. Please, again, so to check, with your local providers around this, and also make sure you're looking at who's the eligible professional as you think through these. Next slide. Again, so you'll contact the carrier, as I said, and see what they use, and test this out. Maybe do 1 or 2 cases to test it out to see, if you can get reimbursed using, the practice that you guys are using there, and then kind of refine or tweak as necessary to make sure that you have a sustainable way to bill for these services. Next slide. So again, there's the other sorts of considerations to look at. One is the physician billing for that service. If so, then you can use, if so, the physician completing the assessment can be included in the overall time. Is the provider individually eligible for payment under Medicaid? If not, then she would not receive payment, but the organization could be eligible for receiving payment, for that service. Medicare has some good guidance around this, learning networks and other fact sheets about this. And this is just another note, and I think most people probably aware of this. So you cannot combine SBIRT with substance use treatment and bill for both. So if you're providing sort of more formal substance use treatment services or in a substance use treatment provider organization, screening and assessment is kind of a part of what you do as an organization. So you wouldn't be able to bill SBIRT services on top of that. So that's all that is there. Next slide. So these are just some resources just from this part of the presentation. As again, the Center for Innovative Health Solutions, where I work, we have a SBIRT sort of clearinghouse where we have a number of different SBIRT-related tools and guidance there. Telemedicine, if you're thinking about SBIRT in that particular venue, is a good website there. Some other information about schools. And then we also have some information about use of SBIRT in other situations on our website. SBIRT Oregon, which is really a great resource there, which talks about reimbursement and some other things. They actually are a pretty good resource around SBIRT, as well as, again, the National SBIRT HTC and their resources in their webinar library and other places. Next slide. So I'll stop now and take any questions you have at this point. And again, Nancy, my colleague there in Nevada, is going to be talking about sort of new technologies and other things related to SBIRT that can be used as you think through implementing this.
Thanks so much, Aaron. That's a lot of information. And I'll be sending all the attendees an email tomorrow morning. I will reference. I do have just a couple questions. In the beginning of your presentation about evidence-based practice, I have a question about what other evidence-based practice.
Chris, your voice is cutting in and out.
Oh, I'm sorry. Thank you. We had a question about evidence-based practices, and the person was wondering what other evidence-based practices are out there.
Well, there are a number of other evidence-based practices around substance use treatment in general. I guess the easiest way to answer that is SAMHSA has a website. It's called NREP. It's the National Registry of Evidence-Based Practices. And that website has a number of different sort of packaged and other manualized programs around addiction treatment. So I was really speaking much more specifically about kind of the larger context of addiction treatment and making sure you're well-versed or your agency is well-versed in kind of those other programs and practices that might be of value to you as you think about kind of formalizing this. But I think NREP is probably the best and easiest way to look at or way to find some of those evidence-based practices. Also, a good recommendation would be the NIDA has a clinical trials network library that has a lot of information there around some of the research-based, evidence-based practices, a lot of the cutting-edge stuff, but really that's been put in peer-reviewed journals, and it looks pretty promising right now. So that would be another good source if you're looking for other evidence-based practices.
Okay, thanks. One other question. They want to know who compiled the new patient workflow chart.
Compiled the new patient workflow. You mean? I'm
is it available? I guess they just asked who compiled it. Maybe we can ask Dave to give us more information on your question, please. Okay. And then I'll get back to it later.
Well, I mean, the workflow itself came from Bill McFeature, who is, I think, he's director of clinical services at a health system down in Virginia. I think it was part of some sort of web-based training or something that he did for Arizona State University. So, I mean, that document is just out there. It's really just a screenshot that was in there. So.
Oh, okay. So, so do you know if that's available? We would just look for that presentation.
I can send the link to that after the presentation. So.
Yeah, that'd be great. You send it to me, and I'll make sure everybody gets that. Then, thank you. And those were the only questions I had. So, Nancy, you want to take over?
Sure. Thank you very much. Erin, you're a difficult person to follow, so I'll try and live up to that. So I'm Nancy Roget, and I'm the PI and Project Director for the National Frontier and Rural ATDC, which one of our focuses is telehealth technologies. Next slide. This is just an example of some of the places where folks live and how do we get drug and alcohol treatment services and mental health services out to those folks. Next slide. What I want to talk with you about today is technology-based interventions and SBIRT. And Erin did a great job of providing an overview of screening, brief intervention, referral to treatment, and some of the implementation issues that people are struggling with when we're looking at delivering screening, brief intervention, referral to treatment services. And so what I want to talk with you about today is to just do a quick review of the literature about how SBIRT is being used with different technologies. Next slide. And so this review of literature by itself, just in the little time that I have, is not totally comprehensive. So I've done just giving you a sampling of some of the ways that technology is enhancing the use of SBIRT in different settings. And next slide. Just as a reminder, and it was fascinating to me to find this particular data point, that really SBIRT research began in emergency rooms. And the earliest study was a controlled trial of 200 dependent drinkers at Massachusetts General Hospital, and it was conducted, you can see, by Dr. Chavez in 1957. So when we talk about SBIRT, SBIRT's actually been around for a long time, and that it originally started, like I said, in looking at emergency rooms, or as most folks call it, emergency departments. Next slide. So today I'm going to do a brief review of technology in SBIRT regarding computer and web-based technologies using laptops and tablets. And I'm also going to highlight interactive voice response, and which is IVRs, or telephone-based computerized programs. Next slide. Also going to talk about the use of these technologies in emergency departments, primary care offices, OBGYN offices, pediatricians offices, and schools. Next slide. So let's start in. Computer technology-based SBIRT has a lot of clinical advantages, and they make them really advantageous for use in healthcare settings. And certainly one of the things that Erin was talking about is absolutely true. When we're looking at implementing SBIRT into different medical settings, one of the first things that folks say is, oh my gosh, we don't have time to add one more screening process and a brief intervention, and oh my God, we don't know how to refer people to treatment, and really we don't even want to ask people about their alcohol and other drug usage. And so the computer-based SBIRT may address some of those issues. Next slide. Also, some of the research shows that when you're using technology to actually conduct screening and brief intervention, you can minimize the bias that can arise in clinical relationships. And as you know, as counselors and therapists, we're always trying to pay attention to our own biases and make sure that those biases don't interfere with the delivery of services. Next slide. Also, using SBIRT technologies, these technologies are able to store information, and so this information about the patient can be used again, and you can do some comparison between, let's say, drinking levels when the patient first came in versus drinking levels at follow-up. Next slide. Also, SBIRT technologies can provide individualized health information to participants immediately after completing the screen and in an engaging manner. And many of those, let me back up, most of the web-based screeners that are available nowadays are sophisticated enough and are programmed to give the user feedback based on their answers, and a lot of that feedback is individualized. And so if I put in my information about my current drinking, and Aaron put in his information about his current drinking, which of course we're not going to do on this particular webinar, and I'm just using that as an example, we would get two different responses based on the information about us that we have entered, based on demographics and based on consumption. So this is a very cool thing that the SBIRT technologies are able to do. Next slide. Also, SBIRT technologies don't require direct clinician involvement, and so you don't have to do a lot of training with clinicians except for how to use the equipment, how to help clients use the equipment, and you know, so you have some of the resistance certainly regarding we don't have the time, we don't have the staff. You can certainly look at combating some of that resistance with this kind of technology. Next slide. Also, using SBIRT technologies to do screening, they can really give you or give the patient a sense of being anonymous or having a lot of privacy, because many people are embarrassed about reporting their actual unhealthy behaviors. And I have a few data points later on in the presentation that we can look at some of the research regarding what people were actually able to disclose to a healthcare professional versus what they disclosed to technology and SBIRT technology. Next slide, please.
This is Chris. I'm getting just a little bit of interference, so if you can check your microphone or phone or nothing.
Okay. Also, these technology-based SBIRT programs have been adapted for different cultures, and also for folks who may have low literacy, and also for folks who may be hearing impaired. So it really expands the use of the SBIRT screening processes. And we know for sure that at least one of the computerized based SBIRT screening programs has been translated into Spanish at this point. Next slide. So computers really offer the potential of delivering cost-effective, individually tailored, evidence-based interventions for an array of health behaviors. They're not just being used for SBIRT screening. Computer-based interventions are being used for all sorts of chronic health conditions, and they've just started to increase their popularity in the use of for addiction-related problems or mental health-related problems. Also, computers offer the potential to reduce the time and resources needed for the implementation of behavioral health measures, and it also allows medical services to provide such measures consistently and with a uniform quality. Some of our experience in working with 4 different medical clinics in Nevada about implementing SBIRT is that we see that some physicians and some practitioners do a pretty good job of implementing SBIRT, where others are not as good. And so we really look at the issue of consistency and uniform quality, where if we're using a computer, certainly those would not be as important issues. Next slide. Probably most importantly, when we look at the literature and we look at the studies that have been done, computer-based screening interventions are really acceptable to patients. And some of you may think to yourself, oh, no, we're going to have people who are not interested in that. And yet, a lot of the research they have done has shown that patients are interested in doing the screening, and that using a computer or a tablet or a interactive voice response that's on a telephone is not a barrier. All right, next slide, please. We'll be talking about SBIRT in emergency departments. Next slide, please. And I think Erin's already touched on this. I'm just going to add some data points to it. Over 130 million people visit an emergency department every year. This creates an opportunity, probably not under great circumstances, but at least it does create an opportunity to screen a large number of people. And this may be folks who would never, otherwise would never been asked about their alcohol use or offered any kind of screening, brief intervention, and referral to treatment. Next slide. In 2006, there were 1.2 million emergency department visits in the U.S., and those were the results of excessive alcohol use. Next slide. And then between 2004 and 2010, there was a 94% increase in the number of emergency department visits related to illicit drug use, reaching an estimated number of 5 million visits. and this comes from the Dawn report, one of the studies that SAMHSA regularly does, 2010. Next slide. And then trauma patients, this is an interesting data point, who present with alcohol intoxication on their first admission are about 2.5 times more likely to return for a new injury compared with patients who were sober when they arrived into the trauma room. And so it makes it even more important that SBIRT services are conducted when we're looking at this kind of data. Next slide. So, what are emergency rooms using or emergency departments using? One of the things they're using is the CASI. And the CASI is a device that is a touch screen tablet or computer that delivers the audit. And it's the full audit. It's done in both English and Spanish. Next slide. And some of the studies regarding the use of the CASI basically show that 2.45% of patients reported at-risk drinking to the in-person screening. This was a comparison between in-person screening and the use of a computer-based screening, whereas 11.5% of patients reported at-risk alcohol consumption to the computer. Next slide. So if we look at this study, the CASI had more than an 8-fold higher probability in screening for at-risk alcohol use over in-person screening. And this is just a very recent study. It's done by the folks out of the University of California at Irvine. Also, when we look at some interesting data points, we have here that emergency department patients followed at 1 and 6 months after taking the SBIRT screening using the CASI that reported substantially lower alcohol consumption. Next slide. Also, a final data point, more than 2/3 of patients at one urban emergency department use mobile phones, texting, and other technologies regularly. This was an interesting study by Rainey and colleagues. And basically what they did as part of their study, and they were studying the use of the CASI, they also asked patients, well, what was their general technology use? And you can see here that certainly 2/3 of the patient, at least reported great use of mobile telephones, texting, and other technology, and the majority were interested in receiving behavioral interventions using technology. So the resistance might not be so much with the patients, but it might be more with us, and that's certainly something we're going to have to consider. Next slide, please. So I'm going to switch to a different topic or a different way of using technology to do screening and to do brief intervention. So we finished talking about the CASI and how it's used in emergency departments. Now I want to talk with you about a study, and this is the second version of a study done where they're looking at a particular type of computer-based brief intervention with postpartum women who are at risk to use cannabis. And so it's called SBI, motivational interviewing. Next slide. And the goal of the software used in the study was to facilitate self-change and or treatment engagement regarding illicit drug use via a single 20-minute postpartum interview session following or using the motivational interviewing principles. And like I said, this is the second study that's been done by, I'm not sure how to pronounce his name, ONDERSMA. It's in the, this is a brand new article that you can find in the JSAT, Journal on Substance Abuse Treatment Technology edition that just came out in January. And so this study basically says can we use technology to help postpartum women who are at risk for using cannabis to recognize their issues? And some of the issues is the reason they're using postpartum women is that it's a critical point to get to them after they've had their child to look if we can decrease substance use behavior. Next slide. So in this particular, with this particular eSBI technology, they use a mobile 3-dimension cartoon character. It's not this one. I'm just showing a picture of probably or what my guess is it probably looks like. And this character's capable of over 50 specific animated actions and did the talking, quote unquote, for the entire program. Next slide. And so the woman is going through answering questions, listening to different portions of the module, and then the computer also, based on the information that she enters, gives some feedback. And so this is an example of some of the feedback that someone might be able to get. So you really seem to feel two ways about this. On one hand, you like the way that smoking marijuana helps you relax and have fun with your friends, but at the same time you think you could really use that money on things for your baby. So you can see this is just an example of some of the personalized feedback that women would get through this particular intervention. Next slide. Here's some data on SBIRT. 61.2% of the participants indicated that they were more likely to change because of their interaction with the software. Of those, over half said they preferred using the software than talking with the medical staff about their marijuana or drug use. And you can see 7% that said, no, I'd rather talk to medical staff, and 37% said, well, I'm not so sure which I would like to do. Next slide. So that's just an example of some technology that's being tested with postpartum women who are at risk for continued cannabis use. And does it include screening? Yes. It's more focused on brief intervention. Let me also talk with you, though, about research studies with adolescents in SBI. And we don't have as, once again, we're not talking about a really robust amount of literature in the work with postpartum women or with adolescents. There's certainly a lot of literature regarding the use of SBIRT technology in emergency departments. And there's actually about 8 studies that showed up in a meta-analysis that really provided some great recommendations for the use of SBI in emergency room departments. So let's talk about some recent studies with adolescents in SBI. And like I said, there's not a lot of literature on this, and we certainly need more in-depth and more comprehensive literature. Next slide. So there's, when you start looking at the information regarding adolescents, where are adolescents? Well, if you look at some of the data, and this comes from the U.S. National Center for Health Statistics, they said, excuse me, that the primary care office is a key setting for screening adolescents. And in the U.S., for adolescents in 2012, there were 73.9 million visits to primary care offices among youth ages 15 to 24. And that's some compelling data to say, hey, we better look at how we can be helpful for pediatricians or primary care physicians to look at doing screening with adolescents. Even though the screening for, SBIRT screening for adolescents hasn't met the U.S. Prevention Task Force criteria yet, there is some indication that it is helpful. We'll go to the next slide. Also, school health clinics, they found, were 21 times more likely to elicit visits for behavioral health issues than other general community health clinics. And this was particularly for minority and other hard-to-reach adolescents. So we need to think of primary care and pediatrician offices for adolescents, as well as school-based health clinics, as an opportunity or a place to do SBIRT screening. And then we'll add the technology piece in as well. Next slide. So there's 2 studies out of particular notice regarding doing SBIRT with adolescents in primary care. The first was a computer-facilitated screening that folks did with the provider then, if somebody screened positive, providing brief advice. And it appeared promising for adolescents who were using substances. But there was not that much difference between those folks who were doing an in-person screening and those folks that were doing the computer-facilitated. Also, when we looked at a different study, computer and therapist-based brief interventions among cannabis-using adolescents presenting to primary care, there was some initial data regarding that the adolescents did fine using the computer-based intervention, and they were amenable to it. Once again, not that much difference between computer and therapist-based interventions. Next slide. So let's look at some school-based screening and brief intervention using computers. And the one study that we have out right now is, once again, part of that JSAT edition, special edition on technology that came out in January. And this is done by Curtis and McClellan and Gavellini. So this comes out of the Treatment Research Institute, Tom McClellan's shop. Next slide. And basically what they did is they developed a computer-based program to do SBIRT. They used the CRAFT as the assessment tool. It provided individual substance use feedback for the student. It had tailored animated short videos, 1 to 2 minutes, on blood alcohol poisoning, the effects of alcohol and marijuana, and peer pressure. And it also had an animated blood alcohol calculator that was able to do customized age, gender, and weight-specific formulas to give feedback to students. Next slide. They presented this in a video game style, and obviously this picture I have here is sort of an old picture of how video games look. Certainly they're much more sophisticated at this point. The students found the video game style engaging, and they also found that the short videos encouraged skill building, self-monitoring, and self-efficacy. This particular study was done in New York. It was done, I believe, with association with Phoenix House. I don't think it was done in urban New York. I think it was done in upper New York State, and it was basically a feasibility study. In other words, looking at, how did the school feel about doing SBIRT screening using a computer? How did the students feel about it? Was it acceptable? Was it easy to use? Was it helpful? And the initial data shows all of those things, that it was helpful, it was easy to use, and that students actually seemed to be more interested in participating with this, and that it was easy for the school to use. Next slide. So I'm going to talk about, we've talked about the different ways that computer-based or web-based programs are being used to deliver screening, brief intervention, referral to treatment. Let's talk about interactive voice response. Next slide. Now, interactive voice response, or IVR, is a telephone-based technology, and it uses touch-tone phones to enable the caller to interact with a computer using the telephone keypad as the interface. So all of you are probably familiar with calling different places and answering questions with using the touch-tone keypad or telephone keypad, or listening to different statements made by folks and then answering that. This has been used in a variety of settings, and it's now being used to conduct SBIRT. Let's go to the next slide. So, interactive voice response is an auditory interactive process that is not hampered by low literacy. So in other words, you don't have to worry about people's reading ability on this. This is all done over the phone. Certainly there's privacy and anonymity are greater. At least this is what some of the researchers talk about with IVR than on a computer screen or a written questionnaire, because others can't see or hear the questions or responses. Touch-tone phones are familiar to folks. They're easy to use. They're more widely available than computers, and when you think about that, it's true. And the hardware and software of a centrally housed IVR system can support multiple clinic sites, and thus there are no on-site installation costs beyond the telephone access. Next slide. So this one study done by Rose and colleagues, and this is out of the University of Vermont. University of Vermont is doing a lot of work about a lot of studies regarding the use of interactive voice response. This particular study used IVR in primary care. And what clients did, or patients did, when they came into the primary care office, they were asked to go to a room and pick up the phone and do their screening with the phone or with the interactive voice response phone. And then the results were printed off when they met with the primary care provider, whether it was a nurse, practitioner, physician's assistant, or doctor, it didn't matter. They went over the results, and then if they screened positive, they were sent back to, which is fascinating, sent back to this IVR, and they used the IVR to get a brief intervention. And then if they screened positive as well and needed a referral to treatment, then they could also get a list of the different treatment providers that were available. In this particular study as well, they also gave them information or access, a phone number that they could call back to access the IVR during off-clinic times. And it's a very interesting study, like I said. Also what we're seeing, though, is IVR is used in the drug and alcohol world, treatment world, more for people calling in and recording sort of a daily diary of their alcohol and drug use, listening to different modules regarding drug refusal skills, or how to deal with cravings. We also see IVR being used a great deal dealing with folks who have other kind of chronic diseases like diabetes, high blood pressure, those types of things. One of the interesting pieces of the study, let's go to the next slide, I think is really important, that after they did the screening, IVR, they screened positive, they got the brief intervention through the IVR, and then they were given access to call back. That 1/3 of the calls back to the IVR were made outside of clinic hours. And so what we're talking about here is a really important piece, is that during off hours, these folks were able to call back and get advice and information regarding their issues regarding alcohol or drug use. Next slide. So, is it time for a new technology? Well, I think it's time for us to make sure we keep our minds open. We look at the research. There certainly is a growing body of research regarding using technology to deliver screening and brief intervention and referral to treatment. I think it's time we talk about it more importantly, and we talk with the researchers and look at what their findings are and how they may be applicable to the work that we're doing. Next slide. I'd be happy to answer any questions that you have at this time.
Okay, thank you, Nancy. The one question we have is about billing. Can you bill for the web or phone as
I understand it right now, yes, you can bill for if you do screening and brief intervention over the phone, as I understand it. But let me check that out just a little bit more. Most of the studies, certainly in the emergency room department and the trauma rooms, we know that screening is a requirement for accreditation for trauma rooms. And so I'm sure that they have figured out a way to do the billing as well. But I can get back to that person, Christine, if you give me the information, and I want to check that out a little bit more. But the studies I read did talk, some of them talked about the ability to bill. Now, I'm not so sure in the school setting, but I think in the medical settings, they should be able to bill.
Okay. Well, if you can just get back to me with that information, I'll make sure all the attendees get it.
Great. Great.
Okay. And then the other question was about let's see, FQHCs. They want to know about technology that can be used there. What about using things like laptops or the tablets to do this?
Oh, yes, that's what, there's certainly good information out there about primary care offices using technology to deliver SBIRT, and they do use computers or tablets, and so certainly the FQHCs would be an appropriate setting for that.
Okay, and is there information about what companies or agencies have used the phone or the web SBIRT service? Look into this further.
I can also send you some information regarding that. We try to be really careful not to promote any specific vendors or anything like that. I can send you some specific information that you can send out to folks of different vendors and what folks are doing. We can also send out a list. I mean, the folks out of University of Irvine are some of the folks who are using CASI, and so we can send you access to those researchers, and I'm sure they would have access to the devices they're using and the programs and whether it's available for general use. That's one, and then we can also look at sending sort of a general thing out regarding different vendors, because certainly you want to make sure that you're using a device that's HIPAA compliant and has all the safeguards for your patients.
Mm-hmm. Yeah, that would be great, without promoting anything in particular, just to get people on the path of finding more information on the services available and the technology available and who might have used them. And
right, and there, there is, like I said, I think her name is Gail Rose, and their group out of, and it's John Hesler out of the University of Vermont are some of the main researchers on IVR. And then the folks I mentioned with the CASI, I don't have their names memorized, but I can go back through my PowerPoint, and I can send you also a bibliography that might be helpful that you could post as well.
Yeah, that would be great. Here's another question for people who are using the tablets or web-based systems. How is that information then transferred to, like, in an emergency room, if they're using a tablet?
I think it's probably, or it has been, in some cases, the researchers, there's a researcher, there's an assistant that will then take that information and work with the emergency room personnel to put it into either the EMR or whatever kind of emergency medical or medical records that they're using. I don't know of any providers that have this as part of their EMR, electronic medical records, so that would be an interesting piece. You can see from the IVR research that was done, the information was then printed out, and so my guess is that the office staff or medical assistants put that information into the patient's chart.
Okay. Well, thank you. I don't see any other questions right now, but I appreciate so much your time and the information you've presented. Same with Erin Williams. Thank you so much. I just want to remind everybody that this webinar is being recorded, and I will send them information about the direct link on the IRETA webinar library website. And I will be in touch over the next few days with all the resources and information that people have given on this. Don't forget to fill out the evaluation forms. They'll be coming about an hour after the webinar ends. So thank you, Nancy. Thank you, Erin. At this time, we will close the webinar.
All right. Thank you.
Thank you.
All right.